All right, well, we might as well get started. Um, so thanks everyone for showing up. Um, Looking forward to talking to you guys about ketamine tonight. Let me get rid of this. Yeah. So the goal for tonight twofold. We're gonna talk a little bit about sort of how to generally read research papers and how to interpret medical research in general. And then we'll be comparing a couple of ketamine articles that have come out within the last few years, looking at some of the complications that can occur with ketamine and how rare they really are. So, um, the objectives today, sort of talking about the general interpretation of research. We're going to be looking at identifying sort of what the core research question is that the study is asking, and that's done in the form of a PICO statement, which we'll talk about what that is. Um, Differentiate between common different study designs, prospective, retrospective, et cetera. Talk about validity, sometimes called external validity, and talk about whether it's applicable to your practice and the patients that you're actually seeing. So why does that matter? Well, we talk about evidence-based practice a lot, and it's not just a buzzword. It's how, particularly if you're, in EMS, the fire service, there's a lot of stuff that's sort of, tradition uninhibited by progress, if you've ever heard that phrase. And that has to do with, oh, well, we've always done it that way. And so evidence-based practice is questioning a lot of that stuff, a lot of that dogma, and questioning it to actually answer the question like, so what actually works? So that we can do the things that work, not do the things that don't work. So it's, we're providing the best care because if something doesn't work, then it's all risk without benefit, right? Even something as benign as seemingly benign as like, rigid cervical collars. Um, they have a lot of downsides. They increase intracranial pressure. They can cause pressure injuries. They cause pain. So even that you would think is fairly benign, but it has downsides with almost no upsides, right? So doing research and evidence-based practice is how we actually get to the bottom of this and choose figure out the things that are actually going to improve our care. So there's 5 steps that we're going to kind of talk through when we're analyzing a research paper. We're going to look at the abstract first to find the PICO, which is the population intervention comparator and outcome. We'll talk about that again in just a second. Talk about what the methods are. Then we're going to look at the methods, which is going to help us figure out what kind of design the study is and who the population was that was involved. And then we're going to look at the results for how many patients there were, what the confidence intervals, and the other statistical kind of stuff. Then we'll read the discussion, which is basically the authors discussing the results and what they mean, most importantly, the limitations that they acknowledge themselves. And then we'll decide if this is valid and applicable to your or my next patient, right? So starting with the abstract, it's called the PICO statement, which is population, intervention, comparison, and outcome. So in most studies, the population is, okay, so who was actually in the study? Okay, so this is, all pre-hospital trauma activations between above the age of 18, right? For, if that was the study population. Or, in these ketamine studies, it's going to be all pre-hospital adults that received ketamine for one indication or another. And so that population, where is it? Like, is this in a certain geographic area? Is it certain services that are, is it only certain services that are, that we're getting the data from? Um, and the intervention is what the study is, if it's an experimental trial, it's what they're doing, right? And what are they comparing that to? So for some studies, they might do like testing a drug against a placebo. So the intervention would be the drug and the comparison would be a placebo. Um, And then the outcomes, what are we actually measuring? And is that relevant? We talk a lot about wanting to look at patient-oriented outcomes. Patient-oriented outcomes are things like mortality or length of hospital stay or pain score, right? Um, a non-patient oriented outcome might be, change in a lab value measurement or something else that's not like I don't know, ventilator free days or something like that. It's not necessarily like oriented for what the patient would want, but it's some other measure. Like, they may look at like, looking at studies like TXA, they may look at drop in hemoglobin. Well, the patient doesn't care if their hemoglobin is drops 2 points or not. They care if they die or if they need a blood transfusion, right? So that patient-oriented outcome in that study might be death or need for transfusion versus, a lab-oriented outcome would be like drop in hemoglobin. So that's the PICO statement. We're hopefully going to be able to get that from the abstract. So the abstract is the movie trailer. It's kind of just gives you an outline for what you're going to be reading and giving ideas. So the next step is looking at the methods section. The methods section is the most important part of the paper, and it's where the truth is often hidden. Um, and that's because it spells out how everything actually was done in the research trial. That's how how the sausage gets made. So they're going to find you're going to find that's where we're going to see things like the study design. So was this a prospective study where they were enrolling patients going forward in time? Or is this a retrospective study where they were looking through an existing database or medical records or something to pick out the patients that they were going to use in the study? So our gold standard, the highest quality evidence that we get is from prospective randomized control trials. So a randomized control trial means that we have an experiment with our patients as we're going forward in time and enrolling them. That's the prospective part. They're being randomized to be either in the intervention or the control group. And so the control is, whatever the standard of care is or a placebo, and then the intervention is whatever we're testing. So those, because of the randomization and going forward in time, these are least prone to bias. Whereas if we're going backwards and we're searching databases and we're trying to, pluck patients out of medical records, there's a potential for bias depending on what your search strategy was or how things are documented in the chart, because that's how you're ending up finding the patient or not. So below that, we've got not quite as good our cohort studies, where we basically you can look at a um, either you can do like a observational kind of cohort study where you're looking at a group of people over time and kind of what happens to them. You can do a retrospective cohort study where you're going to go back and sort of like look at this one point in time, describe kind of what was happening between different groups of patients. Case control studies are used for very specific reasons, and that's usually because the outcome that we're trying to study is very rare. So what they'll do is they'll look for patients that have had a certain outcome and then go back into the record to try and determine if they are exposed to whatever they're trying to test for. Is another retrospective study design, but it's used usually for things that have very kind of things that would otherwise be difficult to study. Um, and then the lowest quality is case reports or case series, which is just very small numbers of patients involved. Sometimes it's really the best you can do because if something is so rare. And of course, expert opinion, expert consensus. Sometimes I call them GobSat recommendations, good old boys sitting around talking. Um, but it's the idea is that we want to look at the study design and we want to know, is this a observational trial? Are we just kind of saying, what happens to a particular group of patients without intervening on them? Is this an experimental, or is this like an experimental trial? Is there an intervention and a control? And are we looking forward in time or are we looking backward in time? And that's going to give us an idea of the potential for bias in the data and in the actual study design. So Next, we want to look at the population, specifically the inclusion and exclusion criteria. Um, so, things like age, um, if they were excluding patients of a certain gender for whatever reason. An example here would be if we're studying, specific, if the research study excludes patients over 65, like for a new, let's say, cardiac medication, and you can't really generalize the outcome of that research to geriatric patients, right? Because the research excluded patients over 65. So, we need to figure out who the population is that was in the study so that we know if that matches the groups that we're treating. So the inclusion exclusion criteria hopefully gives us an idea of, are these similar to the patients that I treat? So then we know if what they found in their trial can be generalized to the patients that I treat, and that's a concept called external validity. So when we're looking through the methods, we also want to look for things like blinding. So did patients know if, what they were, did the patients and the paramedics know if they were getting placebo or real treatment? Did the people abstracting the data or doing the analysis, did they know? Because there's ways that things can get kind of fudged. And it's actually really interesting if you go into studying the placebo effect. Um, if patients believe that, the placebo is going to work, and if the person administering the placebo also seems to believe that it's going to work, the effects of the placebo are actually stronger. So, one of the ways that they'll sometimes try to control for this is when they're collecting data, is they'll survey patients to ask them whether they thought they were in the placebo or the control arm. And hopefully they aren't able to guess with any accuracy, because then we know that the blinding was valid. So, um, blinding, right? Figuring out who knew and who didn't know what. And then, like we mentioned, the outcome, we want to be looking what they were actually measuring, and look for patient-oriented outcomes, right? Like survival, not just lab tests or values. I mentioned hemoglobin earlier. Oxygen saturation would be another one. So, this was associated with an increase in oxygen saturation. Well, does the patient care what their O2 sat is? Not particularly. They want to know whether they're going to, avoid hospitalization, if they're going to get injured, or if they're going to die, right? So, again, we want to look into for those outcomes, looking for patient-oriented outcomes. Usually mortality is a pretty good patient-oriented outcome. All right, then we're going to move on to step 3, and we're going to look at the results. So we want to look at the sample size. How many patients were there? Is this a 300 patient study? Is this a 30,000 patient study? We're going to be looking at the p-values and whether something's statistically significant. Arbitrarily in medicine, we use 0.05 as a cutoff, which means that the results in the trial, there's about there's a 5% chance or a 1 in 20 chance that the results were due to randomness alone. So it just means that, it means there's a 5% chance that if we'd repeated this trial, that, this was just due to random chance that we saw the effect size that we saw. Um, and then confidence intervals. When we give like an average for like an effect or something, the calculated average is the middle of what's the confidence interval. And the confidence interval is a range where we're estimating an effect to occur. So we can we're going to look at all these. So narrower confidence intervals are better because that means that your results are more precise. And wider confidence intervals are less helpful because they give you too much of a range that the result could be in. And so we like narrow confidence intervals, small p-values, and big sample sizes. And then we want to look at the discussion. So discussion is the author's interpretation of what the results are. And there should be a section where they discuss the limitations of the study. And that could be often it was retrospective, it was done at a single center, it's small sample size. They're going to talk about a lot of things that limit the validity of their results. And so they should be pretty transparent about that. And this is often overlooked, I think, when people are talking about research, is they don't think about what the limitations actually were when we're trying to, argue that something is valid or not. All right, and then the last step is we need to decide. Does this apply to my next patient, or how does this apply to my next patient? So we're gonna, sit there and think about it and what it means for us and for our patient. So again, to review that five-step process, we're going to look at the abstract, make a PICO statement. We're going to look at the methods for what the design of the study is. Is this an RCT? Is this a cohort study? Is this retrospective? We're going to look at the results section for the samples, for how big the sample was, confidence intervals, et cetera, to see what they actually found, and then and then read the discussion to see what the limitations were and kind of what the authors think of their results, and then decide if we think this is valid to the patients that we actually treat. And so having covered that, let's move on to talk about the two papers that that we're hoping to discuss. Now, let's see here if I can. I'm going to see if it will let me. No, I can't just drop. Why? Of course. Why would I be able to drop files into the chat? That would be helpful. So instead, what I'm going to do is I'm going to drop two links in. That means I need to share it first. All right, so here's the first trial. Then here is the second trial. So hopefully you guys can open those up and follow along. So we'll look at the second one first, the paramedic use of ketamine for severe agitation and violence. So I'm going to look at the abstract and figure out who the population is. So um, can someone looking at the methods or looking at the abstract? Well, I'll give you a chance to read the abstract first, and then we'll talk about it. So I'll just read it to myself to kind of gauge how much time you need for that. All right. Hopefully, you had a chance to read the abstract. So, um, can someone tell me who the population is in this study? Like, what patients are they actually studying?
Patients who got ketamine in the Austin, Texas area.
So we're using paramedic use of ketamines for severe agitation and violence. I think you might have the other one up. So the first author on the one we're talking about right now is Jonathan Kwong. It's from Canadian Journal of Emergency Medicine. You'll see at the top. But it is pre-hospital patients. And so let's see here if I, so, they're in this one, they're looking at any, so they're looking at three paramedic services in Canada that had any patient that received ketamine between January 1st, 2018 and May 31st, 2022. Um, so based off this, it says manual health record review. Is this a prospective or a retrospective study? Are you looking forward in time or are you looking backward in time?
Retrospective.
Good. Yeah, it's retrospective. So this is a retrospective cohort study, right? There's no intervention and there's no comparison. We're just looking back, we're pulling data, and we're describing what happened. So, one of the limitations with this retrospective stuff is that um, we can only really speak to associations. We can't speak to causations, which you may have heard like correlation is not causation. And that's because without randomization, we can't remove potential bias. So when you look back in time and you look for things that are strongly correlated with each other, you'll find things like ice cream consumption is associated with pool drownings, right? And that's not to say that if you stop selling ice cream, you'll have fewer, pool deaths, but that's because it's hot in the summer and people eat ice cream, right? So there's correlations like that when we look back in time are kind of hard to tease out. So, and then what are the outcomes that they're describing?
Advanced airway placement and cardiac arrest.
Yep. Yeah, good. So, um, did the patient get hypoxic? Did they have like vomiting? Did they code? Did they have to get bagged? And those are the outcomes. Okay, so we looked at the um, abstract. So let's we can get down to the methods because they led with in the abstract over 30% of patients develop adverse events after receiving ketamine, right? That's a pretty striking claim, but that's why this paragraph is going to be probably super important, is defining what actually was an adverse event. So you can see here they're talking about this is giving more information about the size of the service, and there's 200,000 calls a year, and the size of the population they serve, 2.3 million, and how they did the data abstraction. Um, cases were excluded if there were no vital signs reported. Okay, well, how might that bias their data,
I could
right?
see
What,
excluding patients who didn't have vital signs before ketamine, but I can't imagine that patients got ketamine and then no vital signs were documented in the record ever.
right? That would be a bit odd. So maybe they were so agitated the ketamine wasn't successful in calming them down, and that's why they were never able to document vital signs, right? So there might be something different about patients with no vital signs recorded that could bias the results. Um, hopefully missing data is a whole separate thing, but that's something that they'll hopefully talk about later is like, okay, so how many patients actually got excluded because of missing data, right? Um, so they're talking about the indications and like what their protocols are, and then defining adverse events. Um, so they're talking about hypoxia, airway compromise, hypotension, hypersalivation, and emesis. I'm not sure that like vomiting and cardiac arrest should be lumped together, but they did. Um, hypercapnia was not reported because of inconsistent end-tidal CO2 monitoring. Interesting. So they reviewed independently by two people to decide whether the adverse event happened after ketamine was given. And then they gave a 1 to 5 scale of whether they thought the ketamine was responsible, with a tiebreaker if they couldn't come to an agreement. And then in the data analysis, they're talking about the exact like statistics they use in the software for actually doing the analysis. And then we get to the results. So They had 332 cases that they found by searching, and then 19 excluded, right? Only two, to your point, were because no vital signs were documented at any point. Um, and then this is just how the breakdown of why those cases were excluded. So ketamine was drawn up but not given. So it's in the record, obviously, because it's controlled. So, or whatever the equivalent is in Canada. So it's still part of the record, but it wasn't actually given to the patient. Um, but the for whatever reason it's documented the ketamine's in there, but um, it wasn't actually like clinically, seemed to be documented. CPR-induced consciousness, they excluded those patients. Fine. So then that gives them their remaining 313 patients. And then in every study, you're going to see like a table one, which is the breakdown of who was in the study. So you're going to see the breakdown here of male versus female. There's more men in the study, which paramedic service they came from. So two-thirds of the patients are from one EMS service. So they're sort of disproportionately represented based off of the number of patients. Now, we don't know, is that because they're using a ketamine a lot more? So is there something different in the indications? Are they a lot more just trigger happy with getting it? Is it because they're a larger area that's responding to more calls? And so are those patients going to be different from patients in the other areas? So is that happening because this is a more urban agency compared to more suburban agencies, right? So is there something about this skew that could be affecting the results? Chief complaint, first sedative administered, and then any additional sedative doses that were given afterward, which mostly 84% of patients got just the ketamine. And then most, if they needed anything, they only got one more dose of sedative after that. Okay. So then they're looking at the route and the dosing. So um, looks like they're given around 5 milligrams per kilogram on average IM, and then IV they're given appropriately much lower doses. Now looking at what they're calling with their adverse events and what numbers those were, it was mostly hypoxia or airway compromise, some cases of vomiting, and 3 cardiac arrests, 12 cases of hypotension. So and then they are using this score system that with a kind of arbitrary cutoff of 3 for whether they think the ketamine was likely to be involved or not, and what percentage of the time that was. So, what does this tell you here? About what of the 41 uh, of the 41 hypoxia cases, they said 31 had, on a scale of 1 to 5, they said more than 3 was likely being affected. And then, they said that 2 of the 3 cardiac arrests were related. So, like, what does this tell you? Anything? So
Hypoxia might have led to the cardiac arrests.
yeah, exactly. Like hypoxia, hypotension, and airway compromise, like those are kind of like ingredients that could lead to a cardiac arrest. And they seem to be pretty like they're attributing a lot of these cases to the ketamine being given, which is interesting. Um, so let's see here. So here's the limitations paragraph we were talking about. Um, So one of the interesting things about this study is like their most common indication was endogenous causes, which means like severe agitation. So most of the ketamine they're giving is like basically for chemical takedown for agitated patients, which is going to contrast with the other study that we're going to look at in a bit. And it's mostly like 5 mg per kg IM is what they're giving. Um, so looking at the strengths and limitations, they're, had good agreement between the people that are doing the data abstracting. Um, they found similar. rates of adverse events to some other literature that they're citing. Um, and they're they're talking about the intubation. Um, it's with patients that are getting intubated. It's hard because different people will have obviously like different thresholds for intubating people. And, I have had to give ketamine to a patient to get him calmed down, and the trauma attending walks in and says, "Oh my gosh, you need to tube this guy." I'm like, "Well, no, because I did that. I wanted him to be this way, right? So I put him in, gave him the ketamine, right? Um, so it's hard after you give someone ketamine and then you hand them off. Um, it seems like people that get a patient that's been given ketamine tend to jump a little more on going on giving on intubating the patient than if you give the ketamine yourself. Like I don't have a good like citation for that. That's just my observations with things. Um, so they say that their conclusion here is that 30% of patients that receive ketamine have some kind of like adverse event. So what do you think about this study? Like, how does this change what you think you should or should not be doing with ketamine in the pre-hospital setting?
I think it supports the current usage of end tidal and vital sign monitoring after ketamine administration.
Yeah, yes, definitely. Anything else? Yeah, so definitely supports that we need to be monitoring the patient, right? Um, During the M&M that I'm doing next week, we're going to be talking all about ketamine cases. Um, that's the recurring, one of the recurring themes is that ketamine does not like kill or injure the patient. It's almost always the lack of monitoring and ability to respond to something that happens after you've given the ketamine, right? People talk about like, oh, ketamine killed like Matthew Perry. It's like, well, yes, if you gave ketamine to a patient that was in a hot tub and they became unable to manage their airway, something bad might happen. So the issue is not the ketamine, the issue is a lot always kind of the stuff surrounding it. So let's look at this paper now. So this is out of hospital ketamine indications, patient outcomes, and associated mortality. Um, this one is, I'll give you a chance to read the abstract and then we'll talk about it. All right. So who's the population in this study?
Patients who got ketamine from services distributed throughout the country.
Yeah, exactly. This is a big US cohort. Um, and this is another retrospective study. So we're going through the ESO Data Collaborative database, which is a database I use for research. Absolutely massive database. So there's lots and lots. There's like millions of hospital records. There's millions of records in a given year of data there. So this is also a much larger sample. So again, like it's retrospective, so there's no intervention or comparison. We're just talking about patients that got ketamine, and then the outcomes, we're reporting, mortality, which is different from what they're reporting in the other. Um, they are reporting some other. Let's see here. I think they mentioned. So they're mostly concerned with mortality, right? Because this study was done really in the wake of Elijah McClain And as a response to that and some of the concerns about ketamine that were coming up. The authors of the study actually flew to Colorado to testify to, I believe, the Senate there um, to try and advocate for changes to some laws that they were trying to put into effect they wanted to completely ban ketamine from the pre-hospital setting. And so because of this study and the authors going and lobbying to the lawmakers, they were able to get the language changed quite significantly. So the mostly mortality is the big one that they're looking at. And it's a very low rate, right? They had three deaths in their cohort of 330-ish people. On the other one, they said two of them um, couldn't be excluded. They said they thought two of them were associated with ketamine. So that would be, let's see here, more like, um, hold on, I can't do math. So if you like two out of 330, so that's like a 0.6% fatality rate. And here they're saying it's 0.07. Um, so this is like a tenth of the mortality rate compared to the other study. So, what's different about this cohort versus, what they're doing up there in Canada? So, we can go down to the methods section. They're talking about the data collaborative data set that has 8 million records in it, was what they were working with. And then they looked all EMS 911 calls that received any kind of ketamine, regardless of age, dose, route, just anyone that got any kind of ketamine. And so this is obviously going to be a little more challenging to interpret because, they said, in the Canadian study, it was three services and they all use the same protocols. And so the indications are different. This is the entire swath of the US, right? And so people are going to have different protocols, different dosing. That is potentially going to make this a little more difficult to interpret, but at the same time, that's a strength, right? Because instead of 300 patients, they end up with more than like 11,000. So we get those, smaller confidence intervals and other stuff that I was talking about. So they were using like primary impression um, to figure out, whether it was like trauma, altered mental status, behavioral, cardiopulmonary seizure, or kind of what the nature of the call was that the patient got the ketamine for. Um, so then they were also looking at hypoxia and hypercapnia, if there was end-tidal reported, and did that happen after the ketamine is time stamped? So that's another limitation is, all timestamps are approximate, right? So it can be it can be really difficult in this kind of research to try and get down to, okay, well, how much time happened between X and Y. But usually the timestamps in the record are pretty good for like what order did they happen in. Because that's the stuff that when you're filling out your chart, you care about, right? Like, oh, I did these in this order, and whether it was 2 minutes or 5 minutes, I'm not sure, but it definitely had in this order when you're having to enter the timestamps. And so that's one thing, right? They're using the timestamps to determine like, did something happen after the ketamine, right? Which I think is valid because you're like, yes, I gave ketamine at about this time, and then at about this time the SAT dropped, right? You want that documented correctly. Um, so then they went through the patients that died and were basically trying to say, could the ketamine have contributed to the patient's death or not? And unless they could really come to a consensus, then they categorize it as unable to exclude ketamine as a contributing factor for the patient's death, which ends up being a vanishingly small number of cases. Um, so as you can see, they've got 11,000 patients. Um, let's see here. So next we can go to talk about what the results were. So 11,000 patients, about a third were missing the end-tidal CO2, um, which is not super surprising because some agencies may just not have it, or you may not be documenting every call, or it's not coming over in an automated fashion. Um, so let's see here. They're talking about some of the record linkage to patient outcomes, and then what we'll look at the figures in the tables because that's going to really kind of help figure out um, help us understand like what they're actually trying to say here. So there were 8 on-scene deaths and 120 in-hospital deaths that they reviewed to try and determine whether ketamine could be was involved in it. So in the 2 on-scene deaths, the first case was responding for a law enforcement request for a severely agitated patient who was also bleeding from lacerations. Um, the patient got 250 of IM ketamine. Um, and then it took 9 minutes after they gave it to extricate the patient, and then was asystolic. So this sounds this that occurred prior to the recording of any vital signs. So this again sounds like a patient that was perhaps given ketamine and then not monitored closely. Um, right, the patients say that bystanders said the patient was also using meth. Right, that's a another theme that you'll see in a lot of ketamine deaths, particularly ones that make the news, is they blame the ketamine, but the patient was also had like fatal levels of meth in their system at the time they died. So it's probably the meth, not the ketamine, but the ketamine's still going to get blamed. So in the second case where they couldn't exclude ketamine as a cause, um, patient was in her 60s, MVC, alert responsive vital, but she was entrapped, um, distended abdomen, and a closed forearm fracture. She got 4 per kg of IM ketamine during extrication. Um, but so 4 per kg of ketamine, but it's not clear whether it was IM or IV. And then she was found to be in PEA arrest like a few minutes later. So this again sounds like someone that wasn't monitored closely after the administration of the ketamine. And so those are the only 2 cases that they reviewed, and they said, well, could the ketamine have contributed to these deaths? Maybe, right? All the other ones, it seemed clear to them that ketamine was not involved. Um, and then they're talking about the in-hospital deaths, right? And those can be difficult because if they die after a week in the ICU, like I don't know, did the ketamine that they got a week ago actually affect their death, or was it the sepsis that they got from going to surgery, or what, right? So here's their breakdown of the patients. So they've got like 12,000, and then people are excluded for cardiac arrest, like before they got there. Um, they didn't have the timestamp documented for when the ketamine was given or the route. Overall, fairly small number of patients that are being excluded. So it left them with a little over 11,000 patients um, to analyze. I'm curious who these 9 patients were that were released on scene after getting IM ketamine. That sounds very interesting to me to read that run report. Um, and so then they're looking at transported patients um, with a linked ED outcome, right? So that they can actually determine, whether they died or not. And this is the biggest chunk of patients that fall out of here. Um, and we have to ask, like, are patients that don't have their ED outcome linked to their EMS record going to be systematically different than other patients? Um, I'm not sure because if you're getting outcome data, back in your EMR, you're I'm just kind of coming up with reasons here. So if you're paying the extra money to get outcome data in your EMR, then maybe you're in a better funded EMS system, right? And so maybe that affects the kind of outcomes that you have because you have better equipment or whatever, right? Versus if you're not getting that outcome data in your EMS records because you're not paying extra for that feature in your EMR, maybe that's a sign that you're not as well funded. And so, is that also a sign of does that correlate with the community that you're in, right? And so, is that the socioeconomic status of the community being represented there? So, these patients, here's the breakdown again, mostly male, but not quite the same. It was like 75-25 in the other study. It's closer to like 60-40 here. Um, mostly, pretty mostly like 20 to 69 years old. Um, the doses here vary quite a bit by the indication or category, right? So, which makes sense, right? Because you're getting around 4 mgs per kg for the altered mental status or behavioral folks, and then you're getting closer, it's more like zero point 0.5 for trauma slash pain, which is right around that little high for pain dose, but still there. And then, you're different for also the cardiovascular pulmonary cases and then seizure cases as well. Vanishingly small number of people getting more than 10 mg per kg, number of doses, um, and then looking at desaturation after ketamine. Overall, like 16%, right? That's not small. Um, but a lot of those patients, this is an important differentiation here. So this is the people that were hypoxic before ketamine administration, right? And people that had new hypoxia after ketamine administration, overall 8.4%, which is mostly in the behavioral, right? About 10% of people had a DSAT afterward, um, which is something that they would have reported as an adverse event in the first study, but not in this one because they're looking more at mortality. Um, and then looking at end title, and then EMS disposition. Pretty much everyone is um, getting transported except these 7 trauma patients that were released on scene. So I guess they gave them pain dose ketamine and then released them on scene. At least that answers some of the questions. Okay, so we can go to the let's see here. We can go to the discussion where they're saying, we did the study and it's vanishingly small um, people that are having like a serious a death related to ketamine. Sometimes patients desat a little bit. Um, one of the biggest differences in this study compared to the other one is that um, the number one indication in the first study was agitation, and the most common indication in this study was pain control for trauma. So there's big um, differences in practice between US and Canada there. Um, so let's see here. They're talking a little bit about, it may be the size, how quickly the ketamine is given versus the dose amount. Um, and let's see here, admission rate was higher. Overall, like patients that get ketamine tend to have like stuff going on with them, right? They're either, you know, injured enough and you have to think about, there's another thing that we can talk about called confounding by indication, right? There's a reason that they probably chose to give ketamine for pain rather than fentanyl, right? So what are reasons you could think of that you would give pain dose ketamine instead of fentanyl to a trauma patient?
Maybe you already gave a bunch of fentanyl and it's not cutting it.
Okay, maybe the fentanyl wasn't working, right? One thing that I can think of, right? What do opiates do, right? They can drop your pressure. Ketamine doesn't tend to do that. So if someone has a soft blood pressure, ketamine may be a better agent for pain control, right? And so if you choose to give ketamine instead of fentanyl, it's going to be because of differences in like right? Like you chose to give ketamine instead of fentanyl, so there was a reason for that, right? And so those patients are going to be different, and so that's part of the risk of bias in this kind of study. Um, so yeah, comparing and contrasting the two studies, um, the like we said, the oh, half of the patients in the American and the U.S. study were for trauma and pain, versus 80% were either the primary indication in Canada was for severe agitation. Um, and so there's going to be some difference in the adverse event rate, probably because those are different populations to an extent. Um, and you have to decide um, which method you think for is better for assigning causation to the ketamine being involved in the death or not, like having the authors like review it. So this they had two people reviewing it and then giving it like a 5 point scale in the Canadian study, and then the American study. It was, a group of physicians that were reviewing the chart and then had to come to like a unanimous consensus. Um, you know, in the uh, in the Canadian study, about a third of the cases were missing vital signs before ketamine was administered. Um, so, if you don't know what the vital signs were before you administered the ketamine, and then you have abnormal vital signs after you administer the ketamine, did the ketamine cause the vital sign abnormality? I don't know, right? Because we don't have vitals beforehand. And obviously, I'm not saying that, don't give ketamine if you can't get a blood pressure while they're trying to punch you, right? But like, um, it from a research perspective, it's a limitation. Um, so we can talk a little bit. Let's see here. So they're talking about, in the US study, they're trying to say they were kind of defaulting that the ketamine caused it, and then they tried to see, could they exclude it versus this, Likert scale that they used in the Canadian study, the 1 to 5 scale. Um, let's see here. Anything else? I'm just looking through my notes on these. Slightly higher IM dosing. In the Canadian study, they were doing about 5 mg per kg versus average of like 4 mg per kg in the US study. Um, so the most common things were hypercapnia and hypoxia in the American study. Um, and versus, they mostly was like, vomiting and hypoxia in the Canadian study. Um, is this related to the dose? Is this related to the route? Most commonly in both studies, they're able to be managed with basic airways. But again, we're giving this to patients that are potentially very sick. Like you've got polytrauma patients that are, maybe a little bit unstable, and that's why you're giving ketamine for pain instead. Or you have someone that's severely agitated and they have polysubstance on board, so we're not sure, what the interaction between, near fatal doses of meth and ketamine could be, or what is their underlying, physiology, that's going on, right? Because do they also have a heart condition, right, from all of the, meth and cocaine that they've, been using that are now getting them agitated enough to need to have chemical restraint, right? Um, so what do you think? How do these studies make you feel about using ketamine in the field?
It seems that if you monitor the airway appropriately, you should be in the clear.
Yeah, right. Like ketamine overall is extraordinarily safe. It's basically the only sedative that they use in the pediatric ER. Um, and that's because of the physiology of it. We know that your breathing and airway reflexes for the most part stay intact. Um, but you do have to monitor the patient, right? And so all of the cases that have been in the news of bad things happening, and even when we're reading the cases of bad things happening in this, it's usually because the patient's not being appropriately monitored. So, when you're giving ketamine, right, like it can cause sedation and desaturation and other stuff. So you have to be prepared to manage the airway. And whether that's just supplemental oxygen, whether that's bagging the patient, um, right? So yeah, you have to monitor the patient. And then if something happens, you have to do something about it, which is kind of what we do anyway. So it's not a completely set it and forget it drug. But it is overall extraordinarily safe. Other thoughts, or other thoughts, or kind of what you've gotten out of talking about these two papers?
It also seems like the data can be very skewed based on um, your unbiased or rather biased beliefs on whatever you're looking for.
Yeah, exactly. So the data can be very skewed depending on how you're collecting the data, how you're analyzing the data, you know, and what measurement are you using for, what are you defining as an adverse event, versus, mortality. That one's pretty hard to argue with, right? They're either alive or they're not, right? But like with cardiac arrest research, right? Like we talk about, it's not just mortality, but we want neuro intact, like survival, right? And so, um, did these patients get an anoxic brain injury? And there's a bunch of people that are comatose because of this, right? It's not really addressed in here because this, particularly the American study, one of the things that they kind of call out in the discussion there is that it's really hard to do this kind of research for pre-hospital stuff because of trying to link pre-hospital records with hospital records on any kind of large scale is very challenging. Um, and ESO is getting better at doing that, but it's not quite there yet where we can get all the outcomes for every patient every time. Um, so overall, after reading these, do you feel better, or do you feel more scared or less scared about giving ketamine in the field?
Personally, I feel better, mainly because it's kind of driven home the point that ketamine is not a set it and forget it. That once I
Mhm.
give it, I need to pay even more attention to that patient, and I need
Mhm.
to use all my tools to monitor airway saturations, end tidal, et cetera.
Yeah, you just have to be prepared to monitor a patient. Exactly. I think that's the biggest take home is that as long as you're doing that, it's extremely unlikely that anything's going to go very poorly. Um, and if it starts to, you'll be able to address it before it becomes a major issue, right? Um, like I'm going to bet that most of the arrests that they see after giving ketamine are probably hypoxic from the airway not being monitored after giving it, right? Because it's your breathing is still intact, but if your patient's like this, right, they're still going to get hypoxic, right? Even if their respiratory drive is still intact. Um, Anyone else? Matt, I know you were chiming in earlier when we were talking about some of the studies. How do you feel about ketamine administration now versus before we talked about these papers?
Yeah, I've given ketamine a bunch in the hospital and pre-hospitally, so this paper doesn't change my thoughts on using it.
Okay. What do you think of the papers? They at least consistent with your experience, or do you kind of like question the validity of the papers because they don't like jive with what you've seen when you've given it?
The only thing I don't see the papers talking about is if you're going to use ketamine for RSI, because it has
Yep.
historically been a perspective that, sometimes they're just too sick, but maybe you were 2 milligrams per kilo of ketamine was too much or something like that.
Hmm. Yeah. And they didn't specifically address like that indication, like for giving it for RSI, because there's not a lot of agencies that are doing RSI outside of critical care transport. So primary 911 doing RSI in the US is fairly unusual. So I suspect that you would have difficulty with that study, just because getting the numbers. But yeah, there's definitely differences in dosing, right? Even then, like if you give 5 per kilo IV or 4 per kilo IV, usually the only bad thing that's going to happen is the patient's going to be out for longer, which sometimes that's a feature and not a bug. Anyone else have any other thoughts, or otherwise we can wrap up? Cool. Well, I hope you guys learned something about interpreting medical research, and that you feel better and validated about how safe it is to give ketamine in the field as long as you monitor the patient, right?
Thanks.
Yeah.
Yep,
Thank you.
extra monitoring.
Sorry, I didn't catch that.
Definitely need to keep a close eye on and do some extra monitoring, especially with the airway.
Yeah, just keep an eye on them, but they'll usually be fine. All right. Thanks for coming, everyone. Appreciate you.
Thank you, Matt.
Yep.
Thank you.